I need you to stop what you're doing and listen carefully, because what I'm about to share could explain why your memory has been getting worse despite doing everything your doctor told you to do. There are 10 medications that millions of people over 65 take every single day. Medications prescribed by well-meaning physicians, medications that treat real conditions, but medications that have a hidden side effect that almost nobody talks about. They accelerate cognitive decline and memory loss in aging brains. I'm Dr. Scott Franklin, and I've been practicing medicine for 28 years. What I'm about to reveal isn't conspiracy theory or anti-medication fear-mongering. This is published, peer-reviewed research from institutions like Johns Hopkins, Harvard Medical School, and the National Institute on Aging. These studies have been sitting in medical journals for years, but most doctors don't connect the dots between the prescriptions they're writing and the memory complaints their patients bring up 6 months later. A landmark study published in JAMA Internal Medicine followed over 3,400 adults aged 65 and older for more than 7 years. The researchers found that people taking medications with what are called anticholinergic properties had a significantly higher risk of developing dementia. And here's the shocking part. The risk increased with dosage and duration. People who took strong anticholinergic medications for 3 years or more had a 54% higher risk of dementia compared to those who didn't take these medications. 54%, that's not a marginal increase. That's a crisis hiding in plain sight in medicine cabinets across America. Before I reveal these 10 medications, I need to be absolutely clear about something, and I need you to hear this. Do not stop taking any medication without talking to your doctor first. Many of these medications treat serious, even life-threatening conditions. Stopping them abruptly can be dangerous. What I want you to do is become informed, have a conversation with your physician about alternatives, and work together to find the safest approach for your individual situation. I'm also going to tell you that medication number 7 on this list shocked even me when I first saw the research. It's one of the most commonly prescribed medications for people over 65, something that tens of millions of Americans take daily, and most people have no idea it's been directly linked to accelerated brain atrophy and cognitive decline. You're going to want to stay all the way through to that one. Drop your age in the comments right now. Are you 65, 70, 75, 80, or beyond? And tell me honestly, are you taking multiple medications daily? How many prescriptions are you currently on? I read every single comment has no cognitive side effects. Addressing underlying causes like dehydration, blood pressure issues, or inner ear problems is essential. Ginger has evidence for motion sickness without cognitive impact. Medication number 1, the most cognitively damaging class based on current research, is anticholinergic, antipsychotics, and certain anti-nausea medications. This includes drugs like Thorazine, Haldol, and promethazine, which is Phenergen. These medications are sometimes prescribed for severe nausea, agitation in dementia patients, or psychiatric conditions, but they have devastating cognitive effects. A study from the University of Washington found that a single anticholinergic medication from this class, taken regularly, increased dementia risk by over 60%. Taking multiple anticholinergic medications simultaneously more than doubled the risk. The mechanism is the same, blocking acetylcholine, but these medications block it more powerfully than almost any other drug class. Brain imaging studies have shown that people taking these medications experience accelerated brain atrophy, reduced cerebral blood flow, and impaired glucose metabolism in the brain. The tragedy is that these medications are sometimes prescribed to dementia patients for behavioral symptoms, but they actually accelerate the very disease they're trying to manage symptomatically. For nausea, ondansetron has minimal anticholinergic effects. For behavioral symptoms in dementia, non-pharmacological approaches, environmental modifications, and addressing underlying causes like pain or infection are first line. If antipsychotics are absolutely necessary, newer atypical antipsychotics like quetiapine have lower anticholinergic burden, though they still carry risks. Now here's what many doctors and patients don't realize. The cognitive impact of these medications is cumulative. If you're taking 3 or 4 medications from this list simultaneously, which is common in people over 65, the damage compounds exponentially. Researchers have developed something called the anticholinergic cognitive burden scale, which assigns scores to medications based on their anticholinergic effects. Studies have shown that people with high total scores, meaning they're taking multiple anticholinergic medications, have dramatically accelerated cognitive decline. A study from the University of East Anglia found that reducing anticholinergic medication burden improved cognitive function in older adults within just a few months. Let me tell you about a patient of mine, Eleanor, who came to me at age 73 convinced she had Alzheimer's disease. She was forgetting conversations, getting lost in familiar places, and struggling to manage her medications. When I reviewed her medication list, she was taking 9 different medications, 6 of which had significant anticholinergic effects: amitriptyline for nerve pain, meclizine for dizziness, Benadryl for sleep, Detrol for bladder control, a muscle relaxant, and omeprazole for reflux. I worked with her and her other physicians to systematically reduce her anticholinergic burden over 3 months. We switched her antidepressant, stopped the Benadryl and meclizine, started physical therapy for her bladder and balance issues, and tapered her PPI. Within 6 months, Eleanor's cognitive function had dramatically improved. Her mini mental state exam score went from 24, which indicated mild cognitive impairment. She told me she felt like she'd gotten her brain back. Eleanor didn't have Alzheimer's. She had medication-induced cognitive impairment, and it was completely reversible. Here's what I want you to do. Print out the list of medications from this video or take notes. Then make a list of every medication you're currently taking, including over-the-counter drugs and supplements. Schedule an appointment with your primary care physician specifically to review your medications. Bring both lists. Ask these questions. Do I still need to be on each of these medications? Are there alternatives with better cognitive safety profiles? Can we reduce dosages? Are there non-pharmacological approaches we haven't tried? Most doctors are willing to have this conversation when patients bring it up, but they may not initiate it themselves because of time constraints or lack of awareness of the cognitive research. Also, ask about deprescribing programs. Some healthcare systems now have clinical pharmacists who specialize in helping older adults safely reduce medication burden. Be patient. Some medications need to be tapered slowly. Some treat conditions where the benefit truly outweighs the cognitive risk. But in many cases, especially with medications that were started years ago and never reassessed, you may be able to eliminate or switch them. If this video opened your eyes to risks you didn't know existed, if you're realizing that medications you thought were helping might be hurting your brain, I want you to do 3 things. First, subscribe to this channel. I create content like this every week specifically for people over 65 who want truth and evidence, not pharmaceutical marketing. Second, share this video with someone you love who's taking multiple medications. You could be giving them information that preserves their cognitive function and independence for years to come. Third, leave me a comment right now telling me, how old are you? How many prescription medications are you currently taking? Are any of them on this list? Will you commit to having this conversation with your doctor? I read every comment. This community is built on shared knowledge and mutual support. I'll see you in the next video. Protect your brain, question your medications. You deserve clarity, not cognitive fog. Your mind is precious. Guard it carefully. Here's how this is going to work. I'm going to count down from 10 to 1, and for each medication, I'll tell you what it's prescribed for, why it's problematic for brain health after 65, what the research shows, and when possible, what safer alternatives might exist. But first, I need to explain the primary mechanism by which most of these medications damage your brain, because understanding this will help you have more informed conversations with your doctor. Many of the medications on this list are what we call anticholinergic drugs. They block the action of acetylcholine, a neurotransmitter that's absolutely critical for memory, learning, and attention. Think of acetylcholine as the communication system between neurons in your brain. When you block it, neurons can't talk to each other effectively. Memory formation becomes impaired, cognitive processing slows down, and over time, chronic anticholinergic exposure actually causes measurable brain atrophy, particularly in the hippocampus, the region responsible for forming new memories. Here's what makes this particularly devastating after age 65. Acetylcholine production naturally declines with age. By age 70, you're already producing about 30% less acetylcholine than you did at age 40. When you take medications that further block the acetylcholine you do have, you're essentially creating a state of severe neurotransmitter deficiency. Research from Indiana University School of Medicine used MRI brain scans to compare people taking anticholinergic medications to those who weren't. They found measurably lower brain volume and reduced glucose metabolism in the brains of people taking these drugs, changes that are hallmark features of Alzheimer's disease. Now let's get into the specific medications. Number 10 is first-generation antihistamines, specifically diphenhydramine, which is the active ingredient in Benadryl, and chlorpheniramine, found in many cold and allergy medications. These are available over the counter, which makes people think they're harmless. But first-generation antihistamines are among the most anticholinergic drugs commonly used. They cross the blood-brain barrier easily and block acetylcholine receptors throughout your brain. A study published in JAMA Internal Medicine found that regular use of diphenhydramine was associated with increased dementia risk, with stronger associations at higher cumulative doses. People who took Benadryl regularly for sleep or allergies over several years showed cognitive decline equivalent to aging their brain an additional 3 to 4 years. The problem is compounded because many people take these medications daily for chronic allergies or as a sleep aid, not realizing the cumulative brain impact. Second-generation antihistamines like loratadine, Claritin, or cetirizine Zartec don't cross the blood-brain barrier as easily and have minimal anticholinergic effects. For sleep, addressing the root causes of insomnia through sleep hygiene, magnesium or melatonin is far safer than chronic Benadryl use. Number 9 is tricyclic antidepressants. Medications like amitriptyline, Elavil, nortriptyline, Pamelor, and doxepin. These are older antidepressants that are still commonly prescribed, often not even for depression, but for chronic pain, nerve pain, or insomnia. Tricyclic antidepressants are among the most strongly anticholinergic medications in existence. They don't just block acetylcholine, they also affect other neurotransmitter systems in ways that impair cognition. The University of East Anglia in the UK conducted a study following over 40,000 patients aged 65 to 99 for more than a decade. They found that people taking tricyclic antidepressants had a 29% higher risk of dementia compared to those not taking antidepressants. The cognitive side effects are often immediate and noticeable: confusion, memory problems, difficulty concentrating. But many doctors and patients attribute these symptoms to just getting older rather than to the medication. If you're taking a tricyclic for depression, newer antidepressants like SSRIs, sertraline, escitalopram, or SNRIs, venlafaxine, duloxetine, have far fewer anticholinergic effects. If you're taking it for nerve pain, gabapentin or pregabalin may be alternatives, though these have their own considerations. For insomnia, cognitive behavioral therapy for insomnia (CBTI) is now considered first-line treatment and is more effective long-term than medication. Number 8 is bladder control medications, specifically anticholinergic drugs for overactive bladder like oxybutynin, ditropin, tolterodine, detrol, and solifenacin, vesicare. These medications work by blocking acetylcholine receptors in the bladder to reduce urgency and frequency. But they don't just affect the bladder. They affect acetylcholine receptors throughout your entire body, including your brain. A study from the University of Minnesota found that people over 65 taking bladder anticholinergics for just 90 days showed measurable declines in cognitive testing scores compared to baseline. Those taking them for years showed progressive cognitive deterioration. The cruel irony is that these medications are prescribed to help people maintain independence and dignity by controlling bladder function, but they may be stealing cognitive independence in the process. Newer bladder medications like mirabegron, Myrbetriq work through a completely different mechanism and don't have anticholinergic effects. Behavioral interventions like timed voiding, pelvic floor physical therapy, and fluid management can also be remarkably effective. For men, treating underlying prostate issues may resolve bladder symptoms without needing anticholinergic drugs. Number 7, and this is the one I mentioned that shocked me, is proton pump inhibitors, or PPIs. These are acid-reducing medications like omeprazole, Prilosec, esomeprazole, Nexium, lansoprazole, Prevacid, and pantoprazole, Protonix. PPIs are among the most commonly prescribed medications in America. Millions of people over 65 take them daily for acid reflux, heartburn, or to protect their stomach while taking other medications like aspirin or NSAIDs. Here's what most people don't know. Multiple large studies have now linked long-term PPI use to increased dementia risk. A study published in JAMA Neurology followed over 73,000 adults aged 75 and older. Those who regularly used PPIs had a 44% higher risk of dementia compared to those who didn't use them. The mechanism isn't entirely clear, but research suggests PPIs may interfere with the clearance of beta amyloid from the brain, reduce vitamin B12 absorption, critical for brain health, and affect brain pH in ways that impair cognitive function. I've had patients who were on PPIs for 10, 15, even 20 years, often without any attempt to discontinue them or address the underlying cause of their reflux. For many people, lifestyle modifications work remarkably well, elevating the head of the bed, avoiding food 3 hours before bedtime, losing weight if overweight, avoiding trigger foods. H2 blockers like famotidine Pepcid may be a safer alternative for some. Working with a gastroenterologist to address root causes rather than indefinitely suppressing acid is critical. If you're realizing that medications you've been taking for years, medications you thought were completely safe, might be affecting your memory and cognitive function, I want you to do something right now. Hit that like button. And if you're not yet subscribed to this channel, please join us. I create evidence-based content specifically for people over 65 because you deserve to know the full truth about how medications affect aging bodies and brains differently than younger people. Subscribe, hit that notification bell, and let's continue this critical conversation. Number 6 is benzodiazepines. Medications like lorazepam, Ativan, alprazolam, Xanax, diazepam, Valium, and clonazepam, Klonopin. These are prescribed for anxiety, panic attacks, insomnia, and sometimes muscle spasms. Benzodiazepines are particularly dangerous for brain health in older adults. They work by enhancing the effects of GABA, an inhibitory neurotransmitter which slows down brain activity. While this reduces anxiety in the short term, chronic use is devastating for cognition. A study published in the British Medical Journal examined data from 1,796 people who developed dementia and compared them to 7,184 matched controls. People who had taken benzodiazepines for 3 to 6 months had a 32% increased risk of dementia. Those who took them for more than 6 months had an 84% increased risk. The American Geriatric Society has included benzodiazepines on their Beers criteria list of medications that are potentially inappropriate for older adults due to risks including cognitive impairment, falls, fractures, and motor vehicle accidents. Yet they continue to be prescribed widely, often for years at a time. For anxiety, SSRIs or SNRIs are first-line treatment and don't carry the same cognitive risks. Cognitive behavioral therapy is highly effective for anxiety disorders. For insomnia, addressing sleep hygiene, treating underlying sleep disorders like sleep apnea, and short-term use of safer alternatives like trazodone or melatonin are preferable. If you're currently taking benzodiazepines, work with your doctor on a very slow taper. Stopping abruptly can be dangerous. Number 5 is certain antipsychotic medications, particularly first-generation or typical antipsychotics like haloperidol, Haldol, and chlorpromazine, Thorazine, but also some second-generation antipsychotics like quetiapine, Seroquel, and olanzapine, Zyprexa. These medications are sometimes prescribed for schizophrenia or bipolar disorder, but in older adults, they're often prescribed off-label for agitation, sleep, or behavioral issues related to dementia, which is particularly problematic because you're giving a medication that worsens cognition to someone who already has cognitive impairment. Research published in The Lancet found that people with dementia who were given antipsychotics had accelerated cognitive decline and significantly higher mortality rates compared to those not given these medications. Even in people without dementia, long-term use of anticholinergic antipsychotics has been associated with brain volume loss and cognitive impairment. The FDA has issued black box warnings about using antipsychotics in elderly patients with dementia due to increased risk of death. Yet prescribing continues because there are limited alternatives for managing severe behavioral symptoms. This is challenging because these medications are often used in difficult situations. Non-pharmacological approaches to managing agitation and behavioral symptoms should always be tried first, addressing pain, environmental modifications, music therapy, validation therapy. When medication is necessary, working with a geriatric psychiatrist to find the lowest effective dose and regularly reassessing the need for continuation is critical. Number 4 is certain anticonvulsant medications, particularly older ones like phenytoin, Dilantin, carbamazepine, Tegretol, and phenobarbital. These are used for epilepsy but also sometimes for nerve pain or mood stabilization. These medications affect brain function broadly and have been associated with cognitive slowing, memory problems, and attention deficits even in younger people. In older adults, the effects are more pronounced. A study from the Stanford University School of Medicine found that older adults taking older generation anticonvulsants scored significantly lower on tests of memory, processing speed, and executive function compared to those taking newer anticonvulsants or no anticonvulsants. The mechanism involves effects on multiple neurotransmitter systems, including GABA and glutamate, as well as impacts on brain glucose metabolism and cellular energy production. If you're taking anticonvulsants for epilepsy, newer medications like levetiracetam, Keppra, or lamotrigine, Lamictal, tend to have fewer cognitive side effects, though individual response varies. Any change in seizure medication must be done very carefully under close medical supervision. For nerve pain, medications like gabapentin or pregabalin may be alternatives, though these also have cognitive effects that need monitoring. Number 3 is corticosteroids, particularly when used long-term at moderate to high doses. Medications like prednisone, methylprednisolone, and dexamethasone. Corticosteroids are powerful anti-inflammatory medications used for conditions like rheumatoid arthritis, lupus, COPD, asthma, and many other inflammatory conditions. They're often necessary and life-saving, but chronic use comes with significant cognitive costs. Research from the University of Michigan found that long-term corticosteroid use was associated with reduced hippocampal volume and impaired declarative memory, the ability to remember facts and events. Corticosteroids affect the brain in multiple ways. They alter glucose metabolism in brain cells, affect neurotransmitter systems, increase oxidative stress, and may accelerate the accumulation of beta amyloid. A study published in BMJ Open found that people who used oral corticosteroids had a significantly higher risk of cognitive impairment and dementia, with risk increasing with cumulative dose. This is challenging because corticosteroids are often necessary for serious inflammatory conditions. The key is using the lowest effective dose for the shortest possible time. Working with your rheumatologist or pulmonologist to explore steroid-sparing alternatives, using localized treatment when possible, inhaled steroids for asthma rather than oral, and aggressively managing the underlying condition to minimize steroid need are all important strategies. Number 2 is statins, and I need to be very careful here because this is controversial and the research is mixed. Statins are cholesterol-lowering medications like atorvastatin, Lipitor, simvastatin, Zocor, rosuvastatin, Crestor, and pravastatin. They're among the most widely prescribed medications in the world and have clearly demonstrated benefits for reducing heart attack and stroke risk. However, there have been consistent reports, both in research and from patients, of cognitive side effects including memory loss, confusion, and mental fog. The FDA added a warning label about cognitive side effects to statins in 2012. The mechanism may involve cholesterol's critical role in brain function. Your brain is 25% cholesterol, and cholesterol is essential for neurotransmitter function and cell membrane integrity. Some researchers theorize that aggressively lowering cholesterol, particularly in older adults whose brains are already vulnerable, may impair cognitive function. A study published in Pharmacotherapy found that people using statins had a significantly higher risk of acute memory loss in the first 30 days after starting the medication compared to non-users. However, other large studies have found no association or even protective effects of statins on dementia risk, so the evidence is genuinely mixed. Here's my clinical perspective. For people with established cardiovascular disease or very high risk, the cardiovascular benefits of statins likely outweigh cognitive concerns. But for older adults taking statins purely for mildly elevated cholesterol without other risk factors, a careful risk-benefit discussion is warranted. If you're experiencing memory problems after starting a statin, talk to your doctor. Sometimes switching to a different statin or adjusting the dose can help. Pravastatin is less lipophilic, less able to cross into the brain, and may have fewer cognitive effects. Number 1. The most problematic medication class for memory loss after 65 is anticholinergic sleep aids, particularly prescription medications like zolpidem, Ambien, esopicolone, Lunesta, and over-the-counter medications containing diphenhydramine or doxylamine. These medications are taken by millions of older adults every single night, often for years or decades, and the cognitive impact is cumulative and devastating. A study from the University of Washington followed over 3,400 adults aged 65 and older who did not have dementia at the start of the study. Over the next 7 years, those who took sleep medications with anticholinergic properties had dramatically higher rates of developing dementia. The researchers calculated that taking these medications daily for 3 years or more increased dementia risk by more than 50%. Beyond the anticholinergic effects, these medications impair the quality of sleep architecture. They reduce REM sleep and deep sleep, the stages when your brain clears metabolic waste and consolidates memories. So not only are you blocking acetylcholine during the day, You're also preventing your brain from performing its critical nighttime cleaning and repair processes. I've had patients who've taken Ambien or Benadryl every single night for 10, 15, even 20 years. When we gradually tapered them off and addressed the root causes of their insomnia, their cognitive function often improved dramatically within months. Cognitive behavioral therapy for insomnia, CBTI, is now considered the gold standard first-line treatment and is more effective long-term than any medication. Addressing underlying sleep disorders like sleep apnea is critical. Melatonin, magnesium, and improving sleep hygiene are safer initial approaches. If medication is absolutely necessary, shorter-term use of trazodone or Ramelteon, Rosarim, which work through different mechanisms, may be preferable. So what should you do with this information? First, make a list of every medication you're currently taking, including over-the-counter medications and supplements. Be comprehensive. Second, schedule an appointment with your doctor specifically to review your medications. Bring this list and say, I'd like to review whether any of these medications might be affecting my cognitive function and whether there are safer alternatives we could consider. Third, do not stop any medication on your own. Many of these medications require careful tapering or have serious withdrawal effects if stopped abruptly. This needs to be done under medical supervision. Fourth, be your own advocate. If your doctor dismisses your concerns, seek a second opinion. You have the right to understand the cognitive risks of what you're taking and to explore alternatives. Fifth, consider asking for a referral to a geriatric pharmacist or a geriatrician. These specialists are trained specifically in optimizing medications for older adults and reducing polypharmacy, the problem of taking too many medications simultaneously. A process called deprescribing has become increasingly recognized as critical for older adults. Research shows that carefully reducing and eliminating unnecessary or harmful medications often improves quality of life, reduces falls, and in many cases improves cognitive function. Let me share a quick story. I had a patient, Dorothy, who came to me at age 73 complaining that her memory was falling apart. She was terrified she had Alzheimer's. When I reviewed her medication list, she was taking 14 different medications, including Benadryl for sleep, oxybutynin for bladder control, and a tricyclic antidepressant for nerve pain. Over the course of 6 months, working closely with her other physicians, we carefully tapered and eliminated 7 of her medications, substituting safer alternatives where necessary. Her cognitive testing scores improved by 40%. She told me she felt like she'd woken up from a fog. Dorothy didn't have Alzheimer's, she had medication-induced cognitive impairment, and it was completely reversible. Your brain is resilient. Even after years of medication exposure, reducing or eliminating problematic medications can lead to meaningful cognitive recovery. But you have to be informed and you have to be proactive. Here's my challenge to you. Within the next week, review your medications and schedule that conversation with your doctor. Come prepared with questions. Advocate for your cognitive health the same way you'd advocate for your heart health or any other aspect of your well-being. If you found this video valuable, do 3 things for me. First, subscribe to this channel. I create content like this every week specifically for people over 65 who want to protect their brain health and maintain their independence. Second, share this video with someone you love who's taking multiple medications. You could be giving them information that literally preserves their memory and quality of life. And third, leave me a comment right now telling me, how old are you? How many medications are you currently taking? Are any of the 10 medications I discussed on your list? And what's one step you're going to take this week to address this? I read every single comment. This community is built on shared experiences and mutual support. I'll see you in the next video. Take care of your brain. Question your medications. Be an informed, empowered patient. Your cognitive future depends on the choices you make today.